started the timer, and here is your question. Today timer is little different, so we will be able to hear it.
Yes.
Okay. If you have read and understood, considering a clinical examination station, kindly begin now.
Good evening.
Yes, begin.
Good evening. I enter in the room. I will wash my hand. I will introduce to the patient. Hello. Good evening. Myself, Dr. Kuldeep, one of the surgical candidate. How can I help you? Can I know your? Can I confirm your name and date of birth, please?
I'm Tina, 55 years old.
Hello, Kima. Today I have asked to examine your hand, which include touching your hand, looking, feeling, and moving your hand. Is it okay with you?
Yes.
Ma'am, before I start the examination, I will ask you: do you have any pain in the your hand or in your elbow or in wrist joint?
Yes, but you can examine.
Okay, thank you. Ma'am, I want to, hello Kina, can you just roll over your sleeve up to your elbow, please?
Okay.
Ma'am, now I will start with looking at your hand. Just can you bend your elbows for me?
Yes.
I will look for scar, I will look for swelling, I will look for asymmetry, I can look for deformity, I will look for the wasting, and I will look for the nodule. I will check for the nodule from elbow to the wrist and hand. I will look for any I look for Hubbard's nodule, Pochard's nodule. I will look for rheumatoid nodules around the extensor surface of the elbow. I will check for any scar. I will check for any deformity, any scar mark, or any wasting. Now I will look for the skin. I will look for the skin changes, and I will look for the nail changes of the patient. Then I will move to the feel portion of that. Kina, do you have any pain in your elbow or wrist joint? Shall I go?
Yes.
Shall I proceed?
Yes.
Okay. In this process, I will first touch your elbow. I will touch your elbow to your wrist joint, which might feel cold due to the weather. I will rub my hands, and I will, with the back of my hand, I will check with the temperature from proximal to distal or distal to proximal. While then I will check for the radial and ulnar pulses, and I will check for the by manual compression of the bones. I will check for the tenderness of the joints. I will check for the wrist joint. I will check for the elbow joint. I will check for the metacarpal joints. I will check metacarpopharyngeal joint. I will check for the proximal interpharyngeal joint and distal interpharyngeal joint. Then I will check for the squeeze test for the metacarpal heads. Then I will check for the palpate along the ulnar border of the elbow to the wrist joint for rheumatoid nodule.
Yes.
Then Kina, can you just follow my commands? It will include the moving your joints. First we will do it passively. I will move the joint. Then first I will move your joint through the some range of motion. Then it will be followed by the active movement. Then I will start with the movements. I will ask the patient to just make a fist. Then I will ask the patient to splay your fingers. Then I will check for the movements of the wrist. I will ask the patient to just straighten the hand so that the palm should be facing the ceiling. In this way we will checking the wrist dorsiflexion. Then I will ask the patient to close the hands. Then in this way I will check for the palmar flexion. Then I will check. I will ask the patient to follow my commands. I will ask the patient to follow my thumb. Like if the thumb is pointing towards the ceilings, it is adduction. and if it is touching my little finger, it is opposition. If it is extending, it is extension, and if it touching the palmar aspect of the first website, it is adduction. Then I will check. I will check for the muscle. I will check for the neurological examination of the hand, which includes sensory as well as motor. First of all, I will ask the patient. I will touch the patient with the wisp of cotton towards at forehead. I will ask the patient, do you feel this touch? Now I will ask the patient to close the eyes, and then I will check for the ulnar as well as radial as well as median distribution of the nerve. For the radial, I will check for the thumb. For the ulna, I will check for the little finger, tip of the little finger, and for the median nerve, I will check for the tip of the index finger. Then I will separately test for each muscle. For the for first of all, for the flexor digitorum profundus, I will stabilize the PIP joint. Then I will ask the patient to flex the DIP joint. For flexor digitorum superficialis, I will isolate the finger and I will ask the patient to bend it. And then I will check for the wrist extensors, which is supplied by the radial nerve. And then the patient will, I will ask the patient to dorsiflex. Then I will check for the hand function. I will ask the patient to just squeeze my finger with the hand. Then I will ask the patient to squeeze my finger with the help of index finger and thumb. Then I will ask the patient to choose a coin out of my finger. In this way, I will check for power grip, pincer grip, and precision grip. Then I will check for the median nerve. I will tap over the carpal tunnel area. If the patient feels sensation or tingling in the distribution of the median radial two-third of the finger and the thumb, it is positive tenal sign. Then I will ask the patient to just fold the hand and push against each other. If the patient, after chronic compression, after holding it for the prolonged period, if the patient has a symptom, it is a positive Phelan sign, which is diagnostic of carpal tunnel syndrome. Then I will ask the patient to make a figure of OK by pinching the index finger and the thumb, and I will try to separate it, and I will instruct the patient not to do that. If she is able to that, it is the test for the median nerve.
Fine,
Then I
Ms.
will
Crohn, can you please present your case now?
I will thank you the patient. If time permits, I can. I forgot to check the tenderness for the anatomical snuff box. I will thank you the patient, and I ask the patient to dress herself.
Yes.
Today I have examined a 55-year-old female who is a hospital cleaner, who presented with a difficulty on examination. She has a positive tenal sign in the
Yes.
along with positive Phelan test, and with normal hand grip,
Yes.
power grip, hand grip, and this with normal median nerve functions.
So what
No
are your
muscle wasting.
differential diagnosis?
I'm provisionally dealing with carpal tunnel syndrome of 3-month duration.
Okay, good. So how do you suggest to manage this condition?
I will investigate the patient with electron myography along with nerve conduction study, and MRI of the wrist joint to rule out the other etiology of the carpal tunnel. As patient is diabetic and on rheumatoid factor, I will assess the patient with blood sugar as well as rheumatoid factor.
All right. What are the treatment options that you can offer to this patient?
I will first of all I will consult the patient regarding what is the diagnosis, what is carpal tunnel syndrome. I will include the multidisciplinary board in the management, including physiotherapists also. I will start, if the patient is having mild to moderate symptoms, I will give a trial of conservative treatment in the form of analgesics along with the physiotherapy, night sprinting, as well as if there is no relief, then I will go for intracarpal tunnel steroid injections also.
Okay.
If patient doesn't improve over the conservative treatment, then or there is objective sign of weakness, then I will go for carpal tunnel release.
Yes, surgical management. Okay. Considering it's carpal tunnel syndrome, what are the associated high risks with this, or what are the risk factors?
Ma'am, carpal tunnel syndrome is associated with increasing age, female sex. It is seen in white population. It is seen in diabetics. It is seen in amyloidosis, rheumatoid arthritis, acromegaly, diabetes, and space occupying lesion of the carpal tunnel, like aneurysm of the artery. It can be due to anomalous muscle. It can be due to pregnancy also.
All right. Okay. One differential diagnosis was the carpal tunnel syndrome. What are the other two that you could think?
Ma'am, it can be due to
They say
it can be
diabetic neuropathy can be one,
yes,
and there could be cervical disc disease.
yes, ma'am.
So
Yes,
why
ma'am.
I'm saying, because I told you always remember 3 to 4
Yes, ma'am.
differential diagnosis for
I'm for
every case. Otherwise, it was absolutely perfect. This is your field. You knew it, how to do it, and you even remembered what to do to complete your examination. So not much feedback, just this much, that you should at least learn 3 to 4 differential diagnosis. Very good.
yes, ma'am. Actually,
And started your timer, and here is your question. Okay. So if you have read and understood, considering it clinical examination station, kindly begin.
Okay. First of all, I would want to wash my hands,
Yes.
and I'll introduce myself to the patient, and I would also confirm the patient's name and age.
Yes.
Then I would want to explain what I want to do to the patient. I would explain to the patient that I would want to examine, look. I'll have to touch. You have to do 1 or 2 movements, and if
Yes.
she's having any pain, she should let me know so that I stop any particular movement I'm making. Then I would want to I would want her to lie down, and
Yes.
I would want to position her. I'll put the right hand, which is the hand I'm supposed to examine, on a pillow.
Yes.
And once I've done
How much
that,
exposure would you ask for?
ma'am,
How
I would
much
expose.
Yes.
I would expose the entire upper limb, the shoulder and the
Okay.
arm and forearm, and yeah. Then I would also then once I've done that, I would obtain a verbal consent. Then
Yes.
I would commence my examination by, first of all, I would want to inspect, and on inspection, I would want to note the site of the fistula, the size. I want to know the site, the shape, the size, the surface appearance of the skin, if there are
Yes.
any skin changes, if there's any scar, if there's any form of ulceration. I would also want to notice, and also I will note the color, if there's any color change around the skin. In this particular patient, there's a bluish discoloration.
Yes.
So I will take note of that. And once I've done that, I would want to ask her if she's having any pain in the shoulder, because I would want her to raise up her hand. And
Yes.
once she does that, I would examine, I will look at the fistula. If it's normally, it should collapse. And if there's any form of distension, it shows there's an outflow obstruction. If there's a distal obstruction, a distal distension, for example, it shows there's an outflow obstruction. Then I'll tell her to drop the hand. Then I would move to palpation. On palpation, I would want to, first of all, I would ask her again if there's any form of pain before I start touching. I'll do a temperature, a differential warmth.
Very good.
Differential warmth. Then I'll test for tenderness while looking at her. I'll make sure I fix my gaze and I'm looking at her if there's any form of tender, if she's wincing to pain. Then I would also want to feel with my fingers. I want to feel for the pulse, if there's any pulse. Usually a normal AV fistula shouldn't pulsate more, or a minimal pulse. Then I would want to use my palm to feel for a trill. the trill should usually be soft, continuous, and should be a machinery rumbling sound. So it should just, I'll feel that with my palm. Then I would also, then I would want to do an augmentation test. I would apply a pressure on a point that is close to the the point of anastomosis. I expect pulsatility distally, which shows there's some augmentation from the point of inflow, which is the artery, so which is normal. Then having done that, then I would also want to first I also look at the chest, because I will expose our chest. I'll look at the chest if there's any form of distended veins along that side, which will also show some form of obstruction. Then once I've done this, I would then auscultate. I would auscultate for brew. The brew should also be, usually the brew is also a soft, a low-pitched brew, which also has a systolic and a diastolic component. Then I'll also auscultate the heart if there's any form of murmurs. Then once I've done this, I would want to thank the patient. I'll wash my hands and I'll offer assistance to help put on her clothing back if she doesn't mind. Then I would want to summarize my patient afterwards.
Okay. Right. You still have 1 minute, but okay, you can begin. You can present your case. And then
in summary, I've examined a 65-year-old woman that is on irregular hemodialysis for an end-stage renal failure. She has an AV fistula on the right hand, which I think is a radiocephalic fistula. There is an associated bluish discoloration around the site of the fistula. The augmentation test was positive. However, the raising the hand, there was some form of the test was negative on raising the hand. There are no the brew is also normal on auscultation, and there are no murmurs on auscultation of the heart.
So what are your differential diagnosis?
I think she has an outflow obstruction of an AV fistula. There's a complicated AV fistula here.
Okay.
The right radiocephalic fistula.
All right. So what are the differential diagnoses that you'll consider?
The differential diagnosis is dialysis ischemic Still syndrome.
Okay.
And for this, and also it could also be ischemic monomelic neuropathy.
All right. So how would you differentiate between the two?
For dialysis ischemic Still syndrome, the there can be bluish discoloration on touching of there will be warmth, there will be warmness of the hand, okay. And also the radial pulse might be absent. The radial pulse might be absent, and there are also ischemic changes like she has.
All right.
Then for the ischemic monomelic neuropathy, usually it depends on the nerve. It usually affects particular nerves. So it depends on the nerve that is affected. If it's the radial nerve, there will be difficulty in extension of the elbow joint. If the ulnar nerve is affected, there will be difficulty in the movement of the hand muscles. All the functions of the hand muscles will be affected. Then also if it's a median nerve that is affected, the muscles that are supplied by the median nerve will also be affected.
Okay.
And
what are the investigations? Yes. Yes, please.
Okay. The investigation, I'll do a duplex scan.
What type of duplex? Arterial.
That's a hand duplex.
Arterial duplex study. Okay, what are the
arterial duplex?
Yes, what are the treatment options that you can offer to this patient?
The treatment option includes I could ligate the fistula and recite another fistula proximal to the ipsilateral fistula that she has. Then I could also do a banding prior to that. A banding could also help. Yes.
All right. Okay, can you please tell me what was the size of the fistula, because you did palpated it?
Yes. The size
And
is
the
usually
shape?
oval,
Oh,
oval shape.
oval shape, but the size?
Size, I would estimate the size might be about 3 by 4
Yes.
cm in its widest
Centimeter,
diameter.
yes. And you have to see if the surface was irregular, if the overlying skin had any scars. Not your time went off. So this is something that you missed in your presentation when you were presenting your case. Because when you told me what you look for, then you have to tell me the size as well, always. And there was like overlying skin had the brown pigmentation. You did tell me that arm elevation was positive and it made the skin pale distally. All right, now I want you to give you the feedback for the examination. You started off very well. You told me what you look for in the fistula, but you also have to focus on upper extremity, because that's why when I asked you how much you'll ask for exposure, yes, you did tell me. So in the upper extremity, you'll also look for the rest of the arm, like color, edema, if there is venous collateralization over the chest or the shoulder, like anything, see? And then when you're doing palpation, so you did look for the temperature and the tenderness, but at the same time, you should look for the radial pulse with the Doppler, okay? And then you should look for the pulsatility of the fistula, the thrill of the fistula, and then you should also look for the skin pinch test. You should also do, and you should also focus or concentrate on the direction of the flow. Is it how it should be, or is it opposite to how it should have been? So this is very important. Then you did do augmentation test, and then the fistula and the heart auscultation. That was correct. But these are the few things that you have forgotten, because you still had 1 minute. And if you would have done these, that would have taken 1 minute.
Yes. And also, I made a mistake. The dialysis ischemic still syndrome it should be on touching. It should be cold to touch, not warm.
Yes, not cold to, yes. It should be opposite. Yes.
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 And also, I didn't pinch the skin.
You didn't pinch the skin. Yes, I told you. And in the ischemic monomelic neuropathy, there'll be poor wrist extension because of radial nerve, poor function of the intrinsic muscles of the hand, poor thumb opposition because of medial nerve. Yes. And it will be warm. So it was opposite what you told me. So this is something you already know. You have to improve. So you'll go back, you'll listen, and you'll definitely improve for next time.
Thank you, ma'am.
Should work. Started your timer, and here is your question. Right. So if you've read and understood, considering it communication skill station, kindly begin.
Okay, I will come in, I will wash my hand, or I'll use the alcohol-based gel. Hello, good evening. I'm Dr. Fabian Olisa, one of the exam candidates. I've been asked to discuss with you concerning an investigation you would like to do. May I confirm your name and your age, please?
Yeah, I'm 66-year-old male. I'm Mr. Max.
Okay, Max, nice to meet you. Please, I would like to know if what you know so far concerning the investigation and your condition for which my consultant has asked me to talk to you for.
Sure, doctor. Dr. Mann told me because I have suffering from some bleeding through my bottom passage as well as some weight loss for last 2 months. So he want to investigate me. He want to use some camera which was passed through my bottom passage to look for the source of bleeding.
Oh, that's correct. That's correct, Max. The camera test which he said he's going to do for you is called a colonoscopy. And this involves passage of a tube. You can see this diagram I'm drawing right now. Okay.
Yeah.
This is your colon. Okay. Now the camera will be passed is just about this size of my finger, of my index finger. That's about the size. It's attached to a tube that will be passed through your back passage and into your rectum and your large bowel, into your large bowel, the lower part of your large bowel and into the large bowel itself. Okay, it will help us to look at everywhere within your large bowel and determine where exactly is you have the problem for which you are having this bleeding and the weight loss you complained about. And it will also offer us the benefit of taking a tissue or a sample from that growth, if we find a growth or whatever we found there, and we send it for tests to be able to get precisely what is wrong with you and treat you appropriately. But it doesn't hurt anyway, but it's just a little discomfort, Mr. Max.
Doctor,
are you there with
any?
me?
Yeah, doctor, is there any alternative to this? It doesn't look pleasant to me.
Oh, I appreciate your worries about this. Yes, there is actually alternative. The alternative is a series of X-ray tests in which you'll be given a substance to drink, in which we'll give you a substance. We'll pass a substance that is called a contrast, and also we'll pass air into your large bowel, and that will help us analyze your large bowel. But it's just the X-rays that we take. Yes, that one is a little less invasive, but the problem with it is that it doesn't offer us the opportunity to take any sample for further analysis. It will only show the problem, but it may not confirm, assuming we find anything there. Do you understand what I'm saying, Mr. Max?
Yeah, doctor, I am getting on your points, doctor. I will be awake during the procedure, doctor?
During the procedure, we will give you, no, you will not be awake. We are going to give you some medications that will make you will feel a bit drowsy, but you will not be aware of the procedure. So, and that will mean that after the procedure, you may have to stay in the hospital for a short while, but definitely you will go home the same day. So I will advise you come with someone who can take you home after the procedure and after you are awake and you are able to take a couple of some things to eat.
Doctor, do you feel this colonoscopy will help me, or do you feel do I need to have a overnight fasting for this procedure, doctor?
Yes, Mr. Max. What we are going to do is, for this procedure, 2 days before when we plan for this procedure, we will tell you 2 days to the procedure, you will be on low fiber diets, okay, which involves taking things like pap, vegetables, fruits, and basically these are the things you will take. Then a day to the night to the day of the test proper, you will take just clear fluids. You take like coffee, drinks, juice, and all that. So those are the things you will take before the procedure. However, we'll allow you to take water up to 2 hours before the procedure. Is that clear, Mr. Max?
Yeah, doctor. I think it's better I have a colonoscopy then. Doctor, can you tell me what are there any risk factors associated with this procedure?
Yes, Max, there's actually no procedure that is without a risk. Okay. Now, for this one in particular, the risk factor includes you could have bleeding, minimal bleeding after the procedure, but this bleeding usually stop after a short while. Another problem, another risk that may follow this procedure is the risk of perforation. But perforation is quite low. The risk is very, very low. It's rare. Even in my practice, I can count 1 or 2 cases I have witnessed. Then from the drugs we are going to give you, you may have a little drowsiness, maybe low blood pressure and all that. But after a while, you'll be fine. I can assure you that, Mr. Max.
Doctor, I want to tell you, I'm on some blood pressure medicines, as well as I'm on aspirin. I need to change my medication for this procedure?
Yes, Mr. Max. Because aspirin, what happens is you are going to stop aspirin for 7 days before this procedure, because
Doctor,
aspirin will be okay. Go ahead, Mr. Max. Take your time. Take your time. Yes.
But doctor, my physician told me not to stop the aspirin because it is a blood thinner, as he told me.
Yes, Mr. Max. It's a blood thinner, and as such, if for any reason you bleed, if you are on that medication, it will make you bleed more. So it's better we stop. We usually stop it so that you will not bleed so much after the procedure. That is exactly the reason why we ask you to stop it.
Okay, and but about the blood pressure medicine, doctor?
Yes, your blood pressure medicine, you can take it with some water. Like I told you, you can take water up to 2 hours before the operation. So you can take it in the morning before the operation.
Okay. Yeah. Doctor, the tissue which you took through this camera test, after how many days I will have a result of that test? Can you tell me?
Yeah, why? Yeah. It's your right to know, Mr. Max. The tissue usually, when we take it for test, it comes after the result will be out in 2 weeks. And after that 2 weeks, I will put a call across to you, and you will come to the clinic and we'll discuss the whole result with you. Let me confirm that we have discussed this procedure. Okay.
Yes. Right, good. Okay, if you want to complete, you can complete, but time has ended.
Okay, let me confirm, Mr. Max, let me confirm that I've explained the procedure of what we call colonoscopy to you, which involves passing a camera through your back passage to view your large bowel, and possibly we may collect a tissue, and this procedure will be done under mild sedation, and the results of the tissue, if found, will be out in 2 weeks, and we'll discuss the result with you in the surgical out clinic. Is that okay by you, Mr. Max?
Yeah, I'm on the same page with you, doctor. We can go ahead.
Give the consent.
So now I'll give you the consent form to sign.
All right.
Good. Okay, doctor, I can sign. Thank you.
Thank you. Right, now it was very good, both of you, but certain things, Dr. Fabian, you have missed. You started off very well. You explained everything very well. When you were telling about the preparation, you don't start 2 days before, you start 4 days before. When you ask like 4 days before, patient should stop taking any iron containing food, any drugs, any medicines, or any food that will cause constipation, any bulking agent, any fiber diet or anything. And then 2 days before, something that you've told exactly. Then one advice, not to drink alcohol afterwards. This is something important. Right, and then he did ask you about the blood pressure medicines, and you did tell. But then he had to ask you second time. Right, and when Hector was telling that I take aspirin and I have high blood pressure, and my father died also of the heart attack. That's why I cannot stop it. So yeah, you kind of explained it correct.
Thank you.
Yes, good. So that was little feedback. Right, and you can restart aspirin soon after. Right, that was it. Yes, Dr. Kuldeep, would you want to give feedback?
Ma'am, everything is fine. Just I want to ask, ma'am, do we need to stop aspirin for 7 days? Actually, I am
Yes,
not aware of, because
that's what it
even
says.
because
7
it is
days
in
before
the,
the procedure.
yeah, but ma'am, in the clinical practice, we are not stopping it actually. Even for the major surgeries also, it depends upon the dose of the aspirin, whether the patient is taking 75 aspirin or 125 aspirin.
Yes,
Even for the major
75
spine
is the
surgeries
common one.
also,
Yes.
ma'am, even for the major spine surgeries, ma'am, we are not stopping the
No, we
aspirin
are
even.
not.
Yeah, I don't know
No
what
one
is the
does.
practice in.
But here, even here at our place, we don't stop. People are taking it. It's just that for general anesthesia,
Clopidogrel. Yeah,
yes.
if the patient is on clopidogrel, then we will take 24 hour to 48 hour for 3 days minimum, but not for aspirin. I am not sure about what is happening, what is the practice in
This is
UK.
what is written in traditional notes, but I would request you, this is homework for you today. You'll
Yeah, I will
Google
check,
the
ma'am.
NICE guidelines, what the NICE
Yeah.
guidelines says about it. Yes, Dr. Abbas and then Dr. Mahmood.
Thank you, ma'am. I just wanted to make comments on the station, and then maybe talk about the aspirin. For the station, I don't know. While you were talking about the while he asked about the options, the other option, yes, you tried to describe the barium enema, but I think one thing you can also add to that is to tell him that while you were saying, you said something we pass through is large intestine. I think it's easier to say that a fluid will be passed through his backside that would show the outline of his large intestine. That would be easier to
Instead of
understand.
large
Yes.
intestine, your guts or the large intestine is again the medical terminology. Should look
Yes,
for
ma'am.
something more laying.
Yes.
Layman.
Yes, ma'am.
Yes, agree.
Yes, ma'am.
Yes, Dr.
Then,
Mahmood.
then,
Yes.
ma'am, the other option, the other thing I wanted to say is that when I think and a follow up to giving the advantage, while having told yes, the other option is barium minima, then you would say, however, the colonoscopy offers you more opportunity to take a tissue where that will assist you with the diagnosis. That is why
I said that.
Yes, he did say that.
Okay, ma'am. Okay,
Yes,
then for
yes.
the aspirin, Dr. Kuldeep, I think there are new studies that have been done actually that you don't really have to stop it for that. But currently,
in routine, we don't
there's even
stop
a
it.
station. Yes, ma'am. But there's even a station in this MRCS. That's the one talking about the blind man with the
hernia
that's been taking warfarin. As
Yes.
part of the questions in that station, aspirin is one of the questions, and they'll ask you, when do you stop aspirin? When do you stop heparin and warfarin? And when do you stop heparin? So I think it's important for this particular example to note that aspirin is stopped 5 to 7 days pre-operative.
Basically, they want to check your knowledge with these anticoagulants or blood thinning medication. So that's the purpose. Otherwise, in routine, we don't do it. Yes, Dr. Mahmood, you raised hand.
Okay, thank you very much. Thank you very much. I just have a question, clarification. In this station, I noticed that there are some aspects that the actor is the patient himself is expected to ask, and which are actually critical information. For example, the medications, when to stop the medications, and issue of whether he'll be awake or not. That if the candidate will not mention it until the actor or the patient asks. So does that mean in a situation where, because as if the pattern is written in the book, most of these materials is that it's meant to be asked by the actor and not really to be said by the candidate until the actor, you wait for him to ask first. So that's how it actually also always comes in the exam, that in the exam always the actor will be the one to ask. So you always expect, or if there's a possibility that you may be the one to have to say it without him first asking it. Just a clarification.
I'm not sure if I have understood your question correctly, but yes, actor will be asking and actor will be real actor. Okay. And it's the job of the candidate to make sure information has been conveyed and actor has been satisfied at the end.
Okay.
Yes. And you would have to explain all the questions that the actor asks you. You have to make them satisfied. Politely, humbly, they can even ask you repeatedly, who gets what kind of patient? It's hard to say. But these are the actors, okay? Hardly you'll get the real patient.
Okay, okay, thank you.
Have I understood your question? Have I answered your question? I don't know.
It's okay. It's okay.
Or otherwise you can ask again. I don't know.
Ma'am,
Yes, please.
Ma'am, I think his worry is that, you know, sometimes when we read through the material and then we discuss to take our mock session, we sometimes over give information because we already have an idea what that station is about.
Okay,
say, for example,
yes.
if they give us a station on, say, for example, this particular station, and then he already knows that this patient will ask the question about the antihypertensive. So
Yes.
sometimes because you already have the idea, you do, when you are presenting, doing your the initial components of the counseling, you go ahead and tell him, okay, your antihypertensives will be stopped. You can take your antihypertensive with a drop of water in the morning of the surgery. While actually in the question in the book, it was actually the actor that was supposed to ask you, then you then offer that answer. So I don't know, sometimes people get worried that are they supposed to actually mention this while doing their counseling, or they wait for the actor to ask them? Because somebody has mentioned to me once that there was a day I just offered all the information during my counseling, and then the actor didn't have anything to respond to ask me. So they now said, okay, that actually I'm supposed to, that I didn't communicate because I'm supposed to allow for the person to ask me questions so that I can actually communicate, because communication is a two-way thing. So actually I'm confused, just like the way it is. Thank you, ma'am.
Thank you.
I think, I don't know if I can say something.
Yes, you can. Yes, please.
Yes, I think, Dr. Abbas, I understand your worry because you expect certain questions. I think if the actor is not coming forth with those questions, I think there's a way one can put it that, and if you are also on any medication, then maybe the actor can now just say, yes, doc, I'm on so. So I think if you do it that way, the examiner will know that you're trying to get history of the patient being on any medication and what you will tell him. So if eventually the patient does not mention the drugs, I think the examiner should know that you had it in mind to talk about the drugs, but the actor did not ask you. So I don't think you have to.
Will ask you. Remember this. Here, when I ask someone of you to act as an actor, so sometimes you can be very well prepared, other times you cannot be well prepared. So this can create a little confusion. But in the exam, actors will be very professional. They'll remember how to play with your emotions. They'll remember how to test your knowledge, and they'll do it very perfectly. Trust me. They will not forget.
Thank you.
But if they want to confuse you, they'll do their best to confuse you. They'll do everything. Right.
Thank you.
Good. Thank you.
Thank you, ma'am.
Yes. And
Yes, ma'am.
here is the timer, and here is your question, please. Yes. Right. So if you have read and understood, considering its surgical pathology station, kindly tell me what are the differential diagnoses of the lesion that you can think of?
Ma'am, my first differentiation will be a carcinoma
Yes,
colon. Second
yes.
differential will be a pseudopolyp associated with ulcerative colitis.
Yes. Okay,
And third
good.
differential will be a diverticulitis, ma'am.
Very good. All right. A diverticulitis in this age. Does
As ma'am, patient is of under immunosuppression, ma'am, is
okay.
on steroid. That's why, ma'am, I took the last differential as a diverticulitis.
Okay. Can you please tell me what do you understand by the term ulcerative colitis?
Ma'am, it is ulcerative colitis is a condition of inflammatory bowel disease which involving mainly the colon and the rectum, involving it is an inflammatory condition involving the colitis of the with characteristic pseudo polyps and ulcers, ma'am.
Okay. Can you please tell me if this condition is associated with any genes?
It is associated with some tumor suppressor genes and oncogenes like P53 as well as KRAS gene, ma'am, along with ma'am APC gene, ma'am.
Can you please tell me how these genes work? What is their mechanism of
Ma'am,
action?
there are two for the carcinoma. There are carcinoma adenoma sequence. There are mainly two type of variety of genes. One is proto-oncogenes and one is tumor suppressor gene. Ma'am, the proto-oncogenes are the normal genes present in our body which help to regulate our cell growth. When it got mutated, it converted into oncogene, which resulted in unregulated cell growth, which led to dysplasia. And then there is a involvement of the tumor suppressor gene. Normally, tumor suppressor gene regulates the growth of the proliferation of the cells. When it has loss of functional mutation in the tumor suppressor gene, it got reactivated and it led to unregulated growth and leading to carcinoma.
All right. Can you please tell me if you'll do the histology, how would you differentiate ulcerative colitis from Crohn's disease?
Ma'am, in the Crohn's disease, it is a transmural inflammation.
Yes.
It is a transmural inflammation.
And?
It can involve Crohn's disease can involve from mouth to the anus. It
Yes.
is mainly involving the terminal ileum. We can see the skip lesions. We can see the cobblestone appearance in the Crohn's disease. We will see creeping fat. We will see the creeping fat, and we will see the fissures and fistula, as well as we will see the non-caseating granuloma in the Crohn's disease, ma'am. In the ulcerative colitis, ma'am, we will see the cryptitis and we will see the pseudo polyp formation, and it is a superficial inflammation. It is mainly involved in the colon. It might sometime involve the ileum also, that is terminal, and that is called backwash ileitis.
Okay. This patient presents with lesion and she's undergoing surveillance. So if a patient has a history, at what age would you recommend to start surveillance?
Ma'am, as the patient is under surveillance, if there is a high risk factor for the malignancy, I will start the surveillance at very early age, at the age of 12 years only.
Very good. Okay, can you please help me and read what you see in the lesion? What you see in the
Ma'am, there we will see there is an ulcer present over the inner aspect of the gut, ma'am. We can see break in the lining of the mucosa, ma'am.
Okay.
With inflamed mucosa.
Can you please tell me what is the pathophysiology behind ulcerative colitis?
Ma'am, it can be it can be idiopathic, it can be autoimmune against our gut microflora. It can be genetic, ma'am, HLA-DR2, ma'am, HLA-DR2. Ma'am, it can be due to mutations in the node gene, ma'am.
And it could even be geographic. It's more common.
Geographic.
Okay. What are the treatment options that you can offer this patient?
Ma'am, as ma'am, patient is already under surveillance, and if the biopsy, we will investigate the patient and we will take the biopsy. If it turns out to be frankly malignant, then we have to offer him an option of a colitis, ma'am, with defunctional ileostomy, ma'am.
Okay, can you, what do you say, did you say? Total
colectomy,
right,
ma'am.
good. Right, okay, can you please tell me normal function of the APC gene?
Ma'am, APC gene is a tumor suppressor gene, ma'am. It is present on chromosome number 5, ma'am. It is a gateway gene, ma'am. Normally, tumor suppressor genes help in to regulate the cell growth. when there is a loss of functional mutation in this tumor suppressor gene, they become inactivated. So
Yes.
the cell with the damaged DNA or will enter in the cell cycle and it get mutated and turns out to be malignant cell now.
Okay, can you please tell me the risk factors for ulcerative colitis? How can
Ma'am,
you prevent this to happen? Yes. Okay.
ma'am, it can be family. There can be a positive family history, ma'am. It is more present in the it is more associated with the genetic disorders, ma'am, like
Yes.
HLA-DR2, ma'am. It can be associated with the some syndromic, ma'am. It can be associated with autoimmune disorders, ma'am. It is mostly seen in female population, ma'am.
Okay.
And it has been seen associated with the
Can you
like
tell me
familiar
if this patient is not, if any patient with ulcerative colitis is not managed, then what are the complications that can occur?
Ma'am,
Or you should expect?
it can lead to intestinal obstruction. It can lead to malignancy. It can lead to fistula formation. It can lead to gallstone
Not
formation.
fistula
It can
formation with ulcerative colitis.
fissure formation, ma'am.
Fissure. Good.
It
And
can lead to malabsorption syndrome. It can lead to gallstone
yes,
formation, ma'am, and it can lead to extra intestinal manifestations like
for example,
like uveitis, ma'am. Like there can be erythema nodosum. There can be uveitis, and there can be polyarthralgia also. There can be involvement of kidney also, ma'am.
you are confusing with the Crohn's because renal stone formation occurs in the Crohn's,
Okay,
not
sorry, ma'am. Sorry.
ulcerative colitis. Okay, the complications with ulcerative colitis could be diverticulitis, perforation, toxic megacolon, bleeding. The most common is intestinal obstruction.
Okay, ma'am.
Yes, okay. Right. So, right, you told me the surveillance. You told me about the genes. Mostly I've asked you everything. Right. Can you define the term dysplasia? Because you use the term this.
Ma'am, dysplasia is a disorganized cellular growth characterized by hyperchromated nucleus without signs of invasion, ma'am.
Okay, can you suggest few lifestyle changes which can prevent this patient from having
Ma'am,
the risk of colon cancer?
high fiber diet, ma'am. Low fat diet, high fiber diet, low fat
Yes.
diet, and a small alcohol suggestion, ma'am.
Okay, very good. All right. If this patient has an ulcer, can you tell me or can you help me? Sorry. Can you please help me and define the term ulcer?
Ma'am, ulcer is in the breach in the continuity of the mucosa, ma'am.
Okay, good. Right. Well has gone, but I just thought that I'll ask the basic definitions because in this station they can ask you these sort of what is carcinoma, for example. If
Ma'am,
they can ask you how would you differentiate it from tumor, so you should be able to tell the difference between tumor and carcinoma.
yes, ma'am. Ma'am, carcinoma is ma'am, carcinoma, it can be with the invasion of, ma'am, with the invasion of the basement membrane, ma'am, actually disorganized growth,
Then what
disorganized
is tumor?
unregulated.
Then what is tumor? Can you define the
Actually,
term tumor?
actually, ma'am, tumor is a broad term. Carcinoma is a part of a tumor, actually. If it is due to epithelial tissue, then it is a carcinoma, actually. And if it is due to mesenchymal tissue, then it is a mesenchymal tumor, like that.
No.
Matlab, it is a broad, tumor is a broad umbrella in which carcinoma is a tumor of epithelial tissue.
Are you trying to say tumor cannot be, a tumor is always cancerous?
Ma'am,
Yes, this is your homework. You'll read.
yeah, okay, ma'am, I'll check, ma'am.
Thank
I will
you.
read, ma'am.
Here is your question. Once you have read this, tell me please.
Okay.
Yes. So it's just this one question. Right. So if you have read and understood, considering it critical care scenario, kindly tell me, how would you manage this patient?
I will manage according to the critical using ABCD approach.
Yes.
I will manage this patient in the intensive care unit. I will insert central line and urine catheter to measure the urine output. I will try pain management for pain relief.
Can you continue, please?
I will do through random investigations, do routine investigation, CBC, and urea electrolyte, and full blood count. Then I will do ultrasound and CT scan.
Can you please tell me what is your provisional diagnosis for this patient?
Patient most likely have acute pancreatitis.
What are the other differentials that you would consider?
Patient might have acute colitis and ascending cholangitis
And or
perforated disc.
okay, could even be pseudocyst. Okay, can you please tell me what are the causes of acute pancreatitis?
Can be due to gallstone or chronic alcoholism. It can be due to after surgery, for GIT surgery. It can be due to hypothermia.
What are the infections which can cause acute pancreatitis? Can you please name few?
It can be due to Kawasaki virus, can be
Very
due to
good.
typhoid, or due
Typhoid
to
or-
MAP.
Okay, very good. Okay, can you please tell me what is the pathogenesis which lies behind acute pancreatitis?
First is duct obstruction.
Yes,
It leads to bile reflux into the pancreas, which leads to damage of the pancreatic acini.
yes,
Can be due to direct damage of the pancreatic acini by virus or radiation or drugs. And there can be due to protease enzyme release, which leads to pancreatic destruction and also further release of pancreatic enzymes,
yes,
and also due to can lead to lipase, which cause fat necrosis, and also elastase, which cause damage of the blood vessels, hemorrhage,
yes.
and also excessive hemorrhage due to acute hemorrhagic pancreatitis.
All right. Can you name few criteria with the help of which you can diagnose the condition acute pancreatitis? How many
There is
criteria
Glasson
can you name?
criteria and
Yes.
Glasson criteria, and there is Glasson criteria and also Balthasar for instance.
Glasgow criteria, Ransom criteria, Balthazar
Yes,
CT scoring system, and okay, this patient
Abaxis
has
score.
raised serum amylase. You think raised serum amylase is significant test to confirm acute pancreatitis?
No,
So then which test should you do?
lipase.
Lipase, okay. Can you please tell me why the patient has become tachypneic?
Can be due to sympathetic overdrive cause of the
Okay.
pain,
Yes.
and also can be due to respiratory complications such as ARDS or pleural effusion, or can be due to shrinkage of the diaphragm by the pseudocyst.
Okay. What are the complications that you can expect if you don't manage a patient with acute pancreatitis on time?
Patient might have local complications as leg wound or abscess or pancreatic necrosis, and also there may be GI complications such as serious and bleeding, and there may be systematic complications of hypovolemia, shock, and cardiovascular. There may be arrhythmia, and also there may be metabolic complications such as hypercalcemia, and hypophosphatemia, and hyperglycemia.
Okay, if this patient has acute pancreatitis, where do you plan to manage this patient?
Manage it in ICU.
Okay, who would you involve in the management of this patient?
I will involve the general surgeon and the hepatologist and the hematologist.
Okay, patient presents with severe pain. So what are the options that you can use to manage patient's pain?
I will manage according to the WHO ladder.
Yes.
I use non-opioid therapies such as acetaminophen and ibuprofen or both. If it is not beneficial, then I will move to moderate or mild opioids such as codeine.
Yes.
It is not no response. I will move to strong opioids such as morphine.
Okay, patient is in severe pain and you plan to manage it in ITU. Can you please tell me how would you manage the nutritional status of the patient? For the nutrition option?
Patient might need total parenteral nutrition.
Okay, for how
Or
long?
nasogenistomy.
Yes, for how long?
It is depends on the pre-morbid condition and the current condition, also estimated return to the normal.
Okay. Would you or would you not prescribe antibiotics for the patient in acute pancreatitis?
I will describe antibiotic.
Okay. Which one and how much? For how long?
Carbapenemam and quinolone for
For how
7
long?
to 14 days.
Okay. Just suppose if it's acute pancreatitis, there are two conditions when a serum amylase comes out to be normal. Can you mention those?
Too early and too late.
Too early and too late. Okay. Can
Chronic
you
pancreatitis
please
and
tell
hypertension.
me, yes, can you please tell me Ranson's criteria upon admission and after 48 hours?
Okay, on admission, there will be depend on the age, more than 55, and also total count leukocytes, more than 16,000, and also aspartate and lactate dehydrogenase more than 300, and aspartate more than 200, and also serum glucose more than 11 millimole per liter. This is on admission. After 48 hours, there is B fluid secretion more than 6 liter and hematocrit fall by more than 10%. And also there is base deficit more than 4, and also albumin is less than 32 gram per liter.
Okay, this patient had pain and you gave paracetamol to manage the pain. How would you know if patient has had overdose of paracetamol?
Patient may be some symptoms such as nausea and vomiting,
Yes.
dyspepsia, and
it will affect liver function test. So maybe you'll do the liver function test and you'll know that patient's liver has been damaged. Thank you.